permanent pacing and implantable cardioverter-defibrillators. Indications. The main indications for a permanent pacemaker are symptomatic bradycardia associated with bifascicular, heart block, acute myocardial infarction, sinus. No dysfunction or neurocardiogenic syncope. The disease. Specific indications. An implantable cardioverter-defibrillator looks like and can function as a pacemaker, however, it can also deliver low-energy synchronized cardioversion and high-energy defibrillation shocks that are successful in terminating 99% of ventricular fibrillation attacks. The implantation pros complete an acquired atrioventricular block, third-degree or advanced second-degree heart block with any of the following features: symptomatic bradycardia, arrhythmia or other medical condition that requires medications that cause symptomatic bradycardia, documented asystole of more than 3 seconds or any escape beat less than 40 bpm. After catheter ablation of the atrioventricular junction. Atrioventricular block after cardiac surgery that is not expected to recover. Neuromuscular diseases with atrioventricular block. Second-degree heart block with associated symptomatic bradycardia. Chronic bifascicular and trifascicular blocks. Intermittent third-degree atrioventricular block. Type 2 second-degree atrioventricular block. Alternating bundle branch block. After myocardial infarction. Persistent second-degree atrioventricular block with bilateral bundle branch block or third-degree atrioventricular block below the His-Perkins system. Transient advanced to second or third-degree infranodal atrioventricular block and associated bundle branch block. Persistent and symptomatic second or third-degree atrioventricular block. Sinus node dysfunction. Sinus node dysfunction with documented symptomatic bradycardia, including frequent sinus pauses that produce symptomatic chronotropic incompetence. Carotid sinus syndrome and neurocardiogenic syncope. Recurrent syncope caused by carotid sinus stimulation. DOR is similar to that of a pacemaker, but the indications differ and are listed. Indications for an implantable cardioverter. Defibrillator: cardiac arrest due to ventricular fibrillation or ventricular tachycardia not due to a transient or reversible cause. Spontaneous sustained ventricular tachycardia in association with structural heart disease. Syncope of undetermined origin with clinically relevant hemodynamically significant sustained ventricular tachycardia or ventricular fibrillation induced at electrophysiological study when drug therapy is ineffective, not tolerated or not preferred. Non-sustained ventricular tachycardia in patients with coronary disease, prior myocardial infarction, left ventricular dysfunction and inducible ventricular fibrillation or sustained ventricular tachycardia at electrophysiological study that is not suppressible by a class I antiarrhythmic drug. Spontaneous sustained ventricular tachycardia in patients without structural heart disease not amenable to other treatments. Patient preparation. Informed consent is required, and patients are required to starve from midnight in case general anesthesia is required. Procedure. Under local anesthesia, a small incision is sited below the clavicle and a subcutaneous pocket is created. Access to the subclavian vein is obtained and the pacemaker leads are advanced under fluoroscopic X-ray control from the subclavian vein to the brachiocephalic vein, superior vena cava and into the right atrium and right ventricle. Dual chambered pacemakers require the implantation of a pacemaker lead in the right atrium and right ventricle. The Leads are tested to ensure good electrical contact and then connected to the pacemaker, which is then placed into the subcutaneous pocket. The defect is closed in layers. Complications. Complications that can arise include bleeding and infection. Rarely, perforation of the heart can occur. Pacemaker-related complications include fracture and dislodgement of the pacing-led post-procedure care. After the pacemaker has been implanted, a CXR is performed to screen for pneumothorax. Post-procedure ECG is required, and a pacemaker check is performed prior to discharge.